On the left, we have a red circle with a abnormal cancer. On the right, with the larger oval circle, you have the MRI, which is currently the standard of most prostate cancer diagnosis. Almost everybody with an elevated blood test or suspicious finding gets an MRI, which is good because the MRI is a very good way to find and stage tumors to see if it's spread. For example, here's the dark cancer as opposed to the white gland. And to see the spread, this is the seminal vesicle. So you can see if the tumor is broken into the seminal vesicle, which in this case, it had not. Also, the capsule, this is the capsule of the prostate, which is better seen on ultrasound. If the capsule is bulging or broken, the cancer has a better chance of spreading. Since MRI is more widely used, let's look at Gleason 6 or a very low-grade cancer. So this is the right, this is the left. Basically, the cancer doesn't show up. And as I said earlier, a lot of this work was done in the early 2000s. So these are the slides that are showing basically haven't changed much in the last 20 years. The technology is basically the same, it's slightly better. So cancer is red on MRI, and here's an interval cancer on the MRI. This is 6 months later that this started growing. Plus, if you use your finger, this is the area the finger feels. It goes in the rectum, feels here, and completely misses the cancer because you can't feel it. And biopsy. The biopsy probe is 11 millimeters in general. So if you biopsy all of this, you'll get probably nothing, maybe low-grade cancer. This is high-grade cancer, which is missed by the biopsy. So you need the imaging to see that you've got everything. In the beginning, I told you about all the irregular tumor vessels. So this is the Doppler ultrasound. And we use something called 3D Doppler ultrasound, or it's called color ultrasound, or power Doppler, or angio Doppler. It has many names for the technology, but they're basically all the same. They show vessels, measure the vessels, and show the irregularity of tumor vessels, and then follow the vessels. So here, the ultrasound correlates perfectly with the MRI findings. Treatment. How do we measure treatment success? In the 2000s, we started doing what's called ablative treatment. In other words, you would find the tumor, biopsy the tumor, and then if it's a small focal tumor, you would treat it focally, which means if it was within the prostate and small, you could treat it with, you could freeze it, you could treat it with a laser, you could treat it with focused ultrasound. And these are immediate treatments. Why is this important to follow with ultrasound? Because when the tumor vessels go away, the treatment is completed. In other words, you know the cancer is dead when there's no more tumor vessels that are feeding it. With antioxidants and the hormone treatments or radiation, the treatment times vary with each patient. But the point is we have a way of following the treatment. Unfortunately, benign PSA rise is common, even in the absence of cancer. Also, if the cancer is outside the prostate, then the PSA will be from cancer in the bones, for example, or the glands, and it won't be in the prostate. By looking at the prostate, then you can miss the cancer elsewhere. The important thing is to tell the doctor and the patient that the cancer is in the prostate or not in the prostate. And then you look elsewhere with isotope scans, for example. So there's a normal benign PSA rise in radiation treatment. Now, this technology was especially done many years ago, but because the MRI was able to show spectroscopy, that means it's able to show the atom, the atomic nature of a cancer. In other words, the more phosphorus atoms that are in a cancer or in the DNA, the worse it is. So we have ways of following it with advanced MRI. And of course, it correlates perfectly with the diagnostic findings with the blood flow technology. So we use blood flow technology with CT, MRI, ultrasound, and now with the contrast enhanced ultrasound technology. So blood flow technology is, again, the key in the 21st century to finding, evaluating tumors and making sure the treatment is effective. This prostate shows little black areas. The blue arrow points to one of the seeds. Now, of course, where the seeds weren't, because there's no cancer where the seeds are, in an area where there are no seeds, the cancer developed. So treatment is good until there's treatment recurrence, which is common in any kind of cancer treatment. Usually the reason for recurrence is you didn't get it all. This is especially true with skin cancer treatment. And if you treat the prostate cancer and it's on one side, it can recur on the other if you don't treat everything completely. Again, HIFU is focused ultrasound, used worldwide now. It was FDA approved in the United States about 8 years ago. Outpatient treatment, and it works very well for small treatments. So a Gleason 5 or anything above a 5 plus 4 is a total of 9. Anything above 6 is a serious cancer. So you really have to watch it. And the high-grade cancers we watch every 6 months for the ultrasound, and possibly we get an MRI every year or two. So the treatment was successful, except the tumor regrew, an aggressive tumor regrew 4 months later. Antioxidant treatment. The Europeans and many of our alternative concierge doctors are using antioxidants, vitamins and supplements, and a lot of them work. The point is you have to make sure that they're working on your patient, that they're working on you as a patient, because just because something is supposed to work, we have to follow that it's specific for your problem, your time, and your life schedule. Once again, treatment, more red, more tumor, PSA 33. Following it, PSA goes down, beautiful correlation, and tumor gets smaller.